Hi everyone, and welcome to this Ovarian Cancer Action webinar on everything to do with risk reducing mastectomy. My name is George. I'm the Communications and Research Officer here at OCA. This webinar is one in a series of workshops and webinars as part of our Hereditary Cancer Awareness Week. There are still a few sessions coming up, so please do take a look at the programme on our website if there are any that you'd like to join in the next few days. We've also recently set up a monthly e-newsletter specifically for people who have a high genetic risk of cancer, and that includes updates on COVID, research, guidelines, so please do sign up for that if you want to keep up to date with any of that. Some housekeeping, a little bit of information on how this session will work today. So in today's webinar, you should be able to see me and our guest expert. We'll be recording this session so we can share it with you and anyone else who may find it useful in the future. So please don't feel the need to write lots and lots of notes because you'll be able to watch this back shortly when we post it to our website. You'll also see along the bottom of your screen on Zoom, there should be some buttons. So please feel free to ask any questions you have during the session using the Q&A function. And when we do ask those, we'll make sure to keep the questions anonymous and I won't read out any names. If you're in need of technical help, my colleague Faye is also online and you can message her through the chat function, or you can give her a ring on the number that you'll find listed in the email where we have the joining instructions. We'll try to get through as many questions today as possible, but if you do have a burning question that we missed or just didn't have time to get to, please do get in touch. That's through braca@ovarian.org.uk, and we'll do our best to get that answered to you. We should say we're really, really grateful for our expert guests for being here and answering our questions, but just to say this isn't a medical consultation, so please always take your personal questions to your medical team before making any decisions about your care. Right, so to introduce our guest today, we have Miss Joanna Franks. She is a consultant breast and oncoplastic surgeon at UCLH. Thank you so much for being here, Joanna. I know this will be a really interesting session. I'm sure we'll have lots of questions as you speak. So over to you, if you could tell us a little bit about surgery and the options available to women.
So good afternoon. It's always a little bit strange to give a talk to an empty room. So I think that there are probably some people out there who are interested to hear about what we're going to talk about, but please do ask any questions through the chat function. I'm a breast and oncoplastic surgeon, and I spend quite a lot of my time speaking to women and treating them for breast cancer, but also with regards to risk reducing strategies. So there are many women, some of whom I'm sure will be listening to this today, who are known to have an increased risk of developing breast cancer. And that is usually related to a genetic predisposition, of which there are several, but the BRCA1 and BRCA2 mutations are the most commonly known, but it's not exclusively those two. There are other women who are considered to be high risk based on family history alone, that we just don't have a genetic predisposition that we found yet. And understandably, this is a very anxious time for women. So the first thing to say to people is please remain breast aware, but not breast paranoid. So it is very important that you check your breasts about once a month if you're still menstruating, just after the end of your period, because that's when your breast is at its least busy. And if you're no longer menstruating, then either the beginning of the month or the end of the month, something that's going to trigger it for you. Most women have no idea how to examine their breasts at all and find it very anxiety inducing, which I totally understand. The most important thing would be just have a look in the mirror, stand up and see if one side looks like the other. We're all lopsided, I'm afraid, just like if you buy a pair of shoes, one side fits and the other instantly gives you a blister. So it's important that you know the route map of you. Pop your arms up in the air and make sure that nothing looks any different one side to the other when you do that. Pop your hands on your hips and press in and make sure again that nothing looks any different. If that's all you can do and you can't bear to touch your breast because every time you do, you feel something and end up dashing to the doctor, then that's a great service that you're giving yourself. For anybody who is able to have a feel of their breast, then in the shower, just have a feel around and make sure that everything seems the same. Your options, if you are considered to be high risk, are to think about being monitored more closely, or to think about risk reducing surgery. And whilst I know you all want to talk about risk reducing surgery, and that's my favourite bit because that's the bit that I do most of the time, I do want to give you some balance to this. I'm going to talk a little bit about what surveillance options are available. Surveillance is actually done extremely well in the National Health Service breast screening programme. So if you are identified to be high risk because of family history or genetics that are known, then you will be invited to go to your high risk family history surveillance centres, and they're dotted around the country. From the age of 30, although it's coming down to 25 for certain conditions, you will be invited to have regular breast MRI scans. So they're done once a year, and they're done timed to your menstrual cycle. That is extremely important. If we MRI you at the wrong time of the month, then it can give all sorts of false indicators on your MRI scan. So it's generally done between day 6 and 16 of your menstrual cycle, with the first day being the day that you bleed. For those of you who have not yet had a breast MRI scan, they are an unusual compared to other MRIs, because you lie on your tummy with your breast in specially commissioned cups, and it takes about 40 minutes. Now, you need to be aware that the recall rate on a breast MRI in the high risk surveillance program is about 1 in 10. So for every 10 women that we MRI who have no symptoms, we will recall one of you and have a look to see at a particular area that's caught our eye on the MRI scan. For the vast majority of people, it is not an area to be concerned about, but the level of anxiety on a recall is extremely high. When you get to the age of 40, you will have MRI scans and mammograms, and it is important that you attend for both. They're usually done within a month of each other. And this will continue until you get to around 50, at which point you may no longer need MRI scans, but you will continue with yearly mammograms. It's based on breast density. So that's just give you a little idea of what's available apart from surgery. If you are going down the route of surveillance, then that is aiming to find an early change, either before it's become even a breast cancer, so it's just a breast at risk area, or a pre-invasive cancer. If you look at the data, we're finding cancers within this group, but we're finding them very early, before they've spread to the armpit, and the amount of drug treatment you should need should be significantly reduced. Many women, understandably, who have been given a diagnosis of being high risk will have some experience of what it's like to have a relative that's had breast cancer, and that very often influences whether they would like to go down the route of surveillance or whether they would prefer to do risk-reducing surgery. Risk-reducing surgery is something that needs to be very well considered. It's important that you have had the scans beforehand as well. You can't avoid the scanning. That will need to be done beforehand to make sure that there are no underlying concerns that couldn't be picked up on clinical examination. And you will need to spend some time with your surgical team. And your surgical team will either be a breast surgeon with an interest in reconstruction, or a breast surgeon and a plastic surgeon. And it's a little bit variable depending on the service that you're with, a little bit related to the preference of the surgeons that you're working with, and also with what type of reconstruction you may be wanting to think about. So when we talk about risk-reducing mastectomy, there are lots of different options, and I'm going to try and divide those up for you logically. But the idea of all of them, however you have your mastectomy done, is that we remove as much breast tissue as we possibly can. Now, any surgeon, whoever's doing this and by whatever technique, is going to leave some breast tissue behind, because it's impossible to remove all of it. And we estimate that we leave somewhere between 5 and 10% of the breast tissue behind. So you do need to be aware that this is called risk reducing surgery, because it is not going to eliminate your risk completely. It is just going to reduce it, and it should reduce it to be less than population risk. So your risk of developing a breast cancer would be significantly lower than the average woman in the street after you've had this surgery, but it doesn't disappear completely. Now, your options for mastectomy: the simplest type of mastectomy is to remove the breast, taking away the skin envelope and the nipple at the same time, and leave the chest wall flat. This is not an option that every woman wants, but it certainly is an option that some women want. And so it is important that you have had the opportunity to discuss all of these options. And for some women, they feel very empowered by the decision to make themselves flat on both sides. I'm always very respectful of patients and their own choices. I think it's really important that as a patient, you get to understand all your options, what the side effects would be, how complicated the surgery would be, and what the recovery would be like before you make a decision. But for anybody who is wanting more information about having a mastectomy without reconstruction, there is an organization called Flat Friends, which is a group of women who have who feel passionate and extremely empowered by their decisions, and it's a good website to have a look at if that's the way that you think you may want to go. Other women will feel extremely strongly that they want to proceed with a risk-reducing mastectomy, but they would like to rebuild the breasts at the same time, which again is entirely understandable, and it's important that each patient has time to reflect on their different options. That's why it's really important that you meet the right surgical team. If you think about the breast there and you're having risk-reducing surgery, we have no concerns about you having already developed a breast cancer, so there should be no concerns regarding things like your skin. So your skin envelope will be entirely normal. It's the breast tissue underneath that we need to remove. So that's called a skin sparing mastectomy. Now, some women's breast shapes will lend themselves very nicely to a skin sparing mastectomy without having to alter the shape of the breast or the size of the breast, or what we would call medically the ptosis of the breast, but for want of a better word, the droopiness. Because most of us, me included, know that gravity is not our friend, and that with aging, the breast shape can change, and it's not always something that we like. So as part of this work up towards risk-reducing surgery, we can think about adjusting the skin envelope to the breast to give the breast a shape and a size that is more in keeping with a patient's preference, and maybe also more in keeping with their body shape overall. So some women will very much want to be larger afterwards. Some women will very much want to be smaller afterwards. Some women will feel that they've always been quite lopsided and would like that to try and be corrected afterwards. And some women will have felt that perhaps after children and so on, that their breast shape has altered and they'd like to have a more youthful look than they had before. And these are all things that we can consider as we're thinking about the risk-reducing surgery. So we may need to think about reducing the skin envelope or changing it. The other thing that where many women will feel strongly about is their nipples. So as part of this, we can not for every woman, but for the vast majority of women, we can think about trying to keep the nipples. So we can manage that using different surgical techniques. And that would be called a nipple and skin sparing mastectomy, or a nipple preserving skin sparing mastectomy. The one thing that I always say to my patients about this is that the breast is made out of lobules that make milk and ducts that transport milk, and the ducts go all the way to the end of the nipple. And so if you are going to have a nipple preserving mastectomy, we will be leaving a small amount of breast tissue behind. And for some women, that is not a step that they want to consider, and they would like to have their nipples removed. And for some women, they would prefer that they keep their nipples knowing that there is a very small amount of residual breast tissue behind them. The one thing that we need to warn all women who are having a nipple preserving procedure is that those nipples will be, to all intents and purposes, completely ornamental. So they're not going to have sensation and they're not going to react in any way. However, they are your own nipples, and a breast without a nipple doesn't look quite the same as it does with one, because we're all programmed to see one. So it's something to think about with the consultant team that are looking after you. So once we've made a decision that we want to have a reconstruction, and then we've made a decision about what shape or size we want the breast to be and whether we're going to keep the nipple or not, we need to think about how are we going to rebuild the breast into this envelope that we've preserved with the nipple on. And the reconstructive options fall in the main into two. So we can think about using your own tissue, which is an autologous reconstruction, or you can think about using things like an implant. And there are pros and cons to both. So if we start with the implant surgery doesn't require any scars anywhere else on your body, because we are just operating on the breast and we will not need to import tissue from anywhere else. It's generally a quicker operation, and your length of stay in hospital should be shorter without any complications, and your recovery time should also be shorter. I think a realistic recovery time is about 6 weeks. Your hospital stay will be anywhere between 1 night and a couple of nights, depending on surgical technique, your health, and so on. There's no exact rule to these, so these are very broad, sweeping ideas for you. Implants are readily available. There are different types. So some surgeons will want to use an implant which they can adjust as they go along once they've done the surgery. So we can have a little port underneath the skin and we can inflate or deflate them. Some will prefer to put the final implant in one sitting. So it may be a 2-stage or 1-stage procedure. And again, it's very variable between patients and surgeons. The implants are generally either round or teardrop shaped. And again, that will vary a little bit on what your shape is, what your aspirations are, and what the surgeon feels will be best for you. Implants traditionally used to be put underneath the muscle, but we've moved away from that a bit more, although not always. And they now tend to be laid on top of the muscle. And then there's a supporting matrix that's used to help keep the implant in the correct place. And in general, this is an acellular dermal matrix, although there are other products available. The idea of using that to support your implant is to make sure that it stays in the correct position and that it's not putting too much pressure on the preserved skin envelope initially at the beginning of your surgery. With all surgery, you need to think about risks, and some of these are the same for all operations. So general anesthetic risk, bleeding, infection, scarring, concerns with healing, and so on. But with implants, you need to be aware of a couple of things. The first is that an implant reconstruction, whoever does it and however good it is unlikely to last for your entire lifetime without requiring some degree of revision. So for some people, it will be a revision earlier on, depending on how the technique has been used. But for most people, you should be thinking that by about 10 years, you're likely to require a revision of that reconstruction. So it's something that you need to factor in. The other thing that you need to be aware of is that there is an association between implants and something called anaplastic large cell lymphoma. It is incredibly rare. We think the risk is about 1 in 20,000, but it's something that you would need to be aware of. If you were to develop this, and of which there are very few cases that we see, then in the main, the treatment would be to remove the implant and any capsule that's around it. It's very rare that people require any systemic treatment. The side, if you are concerned about things and you have implants in already, then one of the things to look out for would be that your implant suddenly becomes very, very swollen or misshapen. Then that would be a reason to think about having your implants checked. Implants give a very particular type of reconstruction, and they often give a very pert breast, which some women are very pleased with. That's exactly what they're looking for. But for others, they feel that it doesn't give the same kind of natural look as using your own tissue. Patients can find that they feel a bit heavy, because actually breast tissue is not as heavy often as the implants are, especially if you're needing a larger implant to give you the size that you want. Patients can find that they're also a little bit restrictive, because implants don't move in the same way as natural tissue will. So when you lie down, your breast is likely to move a little to the side, whereas when you have an implant in, it's going to stay fixed in a particular position. And sometimes women do find that if the implant is a little bit wide, then the inside of the arm will rub against the side of the edge of the implant on the chest wall, and that can be very irritating. Having said that, it's a good reconstructive option, and for some women it gives them absolutely the body shape and aesthetics that they're looking for. For some women, the idea of using a foreign body is very off-putting. Some women also feel very strongly that they don't want to have risk-reducing surgery only to have increased their risk of a different kind of problem like the anaplastic large cell lymphoma, and they would much rather look for an autologous option, which would be using your own tissue. Now, if you look at the textbooks from many years ago, you will see that the main option that we had was to use the tissue from the back, sitting underneath the shoulder blade. There's a long flat muscle called latissimus dorsi, and we used to move that from the back through to the front and would make a breast with that. It's not an option that many women choose. Currently, we have other options. It is a good flap and it does work, but you're going to have a scar on your back, and you're going to have the breast reconstructive scars on the front. The operations that are much more popular are using the tissue from the lower abdomen. So we just as we know that our body shape can change in terms of our breast shape and size over time, I think most of us recognize that over time our tummy can change a little bit as women. Some of that's related to childbirth, some of that is related to hormonal change. And that lower tissue tummy, which sometimes feels somewhat redundant and can be quite difficult to shift, can actually be very useful when you're starting to think about reconstructive options. So we can transfer that tissue from the lower tummy into the breast skin envelopes that we've preserved when we did the mastectomy in order to rebuild the breasts. That type of reconstruction is referred to usually as a DEP, thinking about it's because of the perforator that it is used in order to do the reconstruction, and that requires microvascular anastomosis, so an operating microscope in order to join the blood vessels together, and those are done with the plastic surgeons. That type of surgery is going to take longer. So whereas bilateral mastectomies with immediate implant reconstructions may take 4 or 5 hours, if you're going to do bilateral DEP reconstructions, that's going to take maybe 8 to 10 hours of operating. Now, for the patient who's asleep, that usually doesn't cause any problems. For the family, it feels like an extremely long day as they're waiting to hear how things are going. It is an operation that takes longer to overcome because you have your reconstructive scars, but you also have the tummy, which will take some time to recover from as well. Not all patients are going to be suitable for this surgery because they may not have enough tummy to produce 2 breasts of the size that they want. They may also have had significant abdominal surgery depending on their previous history. So for those patients who've had an ovarian cancer requiring quite a lot of abdominal surgery, it may be that the blood vessels supplying the abdomen have been, abdominal tissue has been affected and you're not suitable for it. So it is variable, but you do need to be carefully seen by a plastic surgeon. Having had a cesarean section or an appendix does not usually prevent this surgery. So small operations on the abdomen and you can still often proceed with that. it is extremely important that you are a non-smoker. If you are smoking, then your reconstructive options get diminished, because the risk of complication goes up exponentially. However, if you stop smoking for at least 6 months, then we are much more willing to consider all of these options. In terms of other tissue that can be taken, apart from our lower tummy, most women have other areas that we're not so keen on and would be quite happy to remodel if we could. So the inner thigh is an option for people. That does work for some people, although it usually can't make very large breasts from the inner thigh, but it is a little bit variable. And there are some flaps around the top of the buttocks that can be used, although they're not used very commonly. And if that was your only option, you'd really need to see a plastic surgeon who undertakes that type of surgery frequently. Although the surgery from a free flap or an autologous reconstruction takes longer and your hospital stay will be longer, it does have some advantages. So you are less likely to require further revisional surgeries, 5 or 10 years down the line. Once it's done, it usually doesn't require anything further than that. You may require the little tweak in the first 6 months to a year day case, just to flatten a little scar. But apart from that, it's not like implants where you are committing yourself to further surgery down the line. The tissue is all of your own, so there's no foreign feeling to it. And once it's settled in its new pocket, very often patients don't really notice that they've had it done, because it feels just like their own tissue. It's nice and warm like their own tissue. It moves like a normal breast, whereas an implant is much more rigid. So from that perspective, it works very nicely. The breasts will age more naturally as well. So whereas an implant reconstruction that you had done in your 30s, which looks very perky, may not be quite the look that you're going for in your 60s, the DIEP or autologous reconstructions tend to age with you, so that they will become appropriate to your body frame as you get older. So that works very nicely for people. Again, with weight change, they also change a little bit, so that also works. It's in keeping with your body habitus as you go along. So for people who are considering this surgery, it is a bigger investment up front in terms of the commitment to the surgery and the recovery. But once you are recovered from it, it should require very little servicing in the long run and will enable you to just get going. Complications associated with this, well, one of the first things to say is that I think it takes at least 12 weeks to get over this type of surgery. So at 6 weeks you feel better, but you're not nearly in the same position as the implant-based reconstructions will be. But by 12 weeks you really should be very well recovered from this surgery. The complications are really related to the blood supply to the flap. So you need to make sure that that microscopic anastomosis of the vessels together, and these vessels are 1 millimeter big, works well, and that the blood supply to the tissue is good, and that will leave you with a nice soft reconstruction on both sides. To do bilateral DIEPs means that you will have to have good vessels on both sides of the abdomen to make sure that we are able to plumb in a reconstruction on both sides. So all patients require a CT angiogram prior to this surgery, and it really is important that the blood vessels are reviewed by the plastics team to make sure that they have enough options to be able to support this kind of surgery. I think one of the other things that's really important to say is that this type of surgery is not something that is going to be undertaken lightly. You do need to have time to think about it. You certainly need to have time to have contemplated all the options. You also need to have a therapeutic alliance with your team. So you may not like everything that your surgical team has to say to you, because sometimes conversations can be very difficult, but you do need to feel that it's the right person telling you, and that you appreciate that you are both traveling along the journey together and going for the same aims. And if you don't feel that, then it's really important that you look to make sure that you can be under a team where you feel that alliance, because all reconstruction is a journey. You cannot assume it's going to be one operation and some recovery and it's all going to be better straight away. It does require often a little tweak here or there, certainly multiple trips to the hospital, and you need to feel that the team you are under are giving you the support and the confidence that you need. Most people don't realise that you can get a second opinion on the NHS, so it is important that you use that if you need to. In terms of risk-reducing surgery and COVID, or even just surgery and COVID, you know, right at the beginning of COVID, there were issues around capacity and safety, although time-critical breast cancer surgery still did continue. There was a time when reconstructions were limited, and there was a time where we were not doing risk-reducing surgery. Things are now much better. We have confidence about our capacity, we have safe pathways, and we are able to offer this surgery. So risk-reducing surgery is now restarting, but it's going to take a little while for the patients to start coming through to be giving dates, but it is happening across the country. So I've given you a very brief overview on what your options are, the most important being around breast awareness, and then about surveillance, and then about different surgical options. It really isn't one size fits all. It is a bespoke thing. It has to be patient-centered, and it has to be what feels right for you and what's possible for you, because there will be restrictions on what can be done based on someone's health, their body habitus, their other underlying medical problems, and so on and so forth. So I think there will probably be some questions now, and then if there is time, I can expand on anything that anybody wants to discuss.
Wonderful. Thank you so much, Joanna. That was a really clear explanation of all the choices that are available and the side effects, and I think it's so important to touch on surveillance as well, because that's absolutely a really important topic to explore and understand a bit more. And thank you also for the breast aware message. I think that's a really important one to get out at the moment, particularly as, of course, understandably, there's a lot of worry or concern about, you know, going to the GP or contacting the hospital, and I think that's really important to push that message that it's absolutely good to stay on top of any symptoms you're experiencing and speak up if you're concerned. So thank you. So our first question that we've had in the Q&A box, so everyone please do feel free to add in questions as we go. One person asked, after risk reducing surgery, is there still a need to have checkups and scans if the risk is reduced? Or
so it's an interesting question, and the risk is very much reduced. You certainly wouldn't be having any mammograms, and most patients and institutions in the UK don't MRI, but we do keep an eye on patients. So you will have a clinical examination, especially as the reconstructions are settling, because it takes some time for the skin flaps and the nipple and the reconstruction to settle. So you'll have follow up until that's all settled, at which point you are likely just to be asked to remain aware of your new chest wall, and if there are any concerns, to come back. So it's not usual to be asked to come back for regular imaging. If you have relatives who live abroad, you may find that things are slightly different. So there are some countries where you will still be offered MRI scans, but there would be no indication for mammograms, and it's certainly not something that's being done routinely in the UK.
Fantastic, thank you. We've also had another question come through about recovery. After DIEP flap reconstruction, is there still a need to wear a bra?
So there will be in the short term, definitely, because plastic surgeons and reconstructive surgeons are obsessed with how things are going to look afterwards, quite rightly, as are patients. So you may have some very special dressings on afterwards. So there are some new, quite high-tech dressings after surgery, which we can use, which have a sort of vacuum system in them, which help to reduce any fluid buildup and improve the blood supply to the skin and to a retained or preserved nipple. So you may have that on for a week to 10 days. You're likely to have some tape on over the scars. Plastic surgeons love tape. In fact, if they can, they'll tape you up for about 6 weeks and send you home with tape to replenish after you've had a shower. And bras will be important. Most reconstructive surgeons like you to be in a bra almost night and day for the first 6 to 12 weeks after surgery, and thereafter you may not require a bra. For those who have implants, it's very unlikely that you will need a bra, but most women still wear one because it's what we're used to doing most of the time. For DEPs, I think because it's a more natural reconstruction, then it's very likely that you will still be wanting to wear a bra, but certainly for about the first 12 weeks after surgery.
Great, thank you very much. So you covered really well the different types of surgery and options that are available to people undergoing reconstruction. I was just wondering if we could kind of elaborate more on how do different reconstruction options, how do they affect someone's ability to exercise or do physical activity?
So one of the things that a reconstructive or plastic surgeon will ask you what your hobbies are and what you like to do, because it's important that we factor that in for your reconstruction. We don't want to do something that is going to make it extremely difficult for you to carry out things that are very important. So in the short term, we are likely to curb quite a lot of vigorous activity. So whilst we're very keen for patients post-operatively to be getting up and walking around, we don't really want you to be jogging, which is something that lots of my patients want to do. Open water swimming in ponds is also something that lots of my patients want to do, and that's the kind of thing that we're going to also say no to for at least 12 weeks. Unless you are a professional athlete or are very committed to a particular type of sport that is going to require, for example, absolutely no loss of your abdominal core, then for the most part, once you are recovered from surgery, we would expect you to be able to go back to all the things that you were doing before. But you need to think about the fact that you are going to have to do these things slowly. So you are not going to go from doing nothing for 12 weeks, 6 to 12 weeks, depending on your type of reconstruction, to running a marathon the following week, because your fitness will be affected, and we also won't want you to build it up too much. When we used to put implants routinely underneath the chest wall muscles, then there was a long time that we didn't want a lot of upper body work being done, because we were very concerned that by tensing those muscles, you may displace the implant, and we really wanted it to settle. But we are now putting them, they're much less likely to be under the muscle these days, and therefore we're not going to stop you doing all of that upper body work, but we are going to stop you doing it for 6 to 12 weeks. The same with, you will be able to shower after your surgery, but you won't be able to get the reconstructions wet usually for the first 10 days to 2 weeks, and then when the dressings are changed, we will then start to think about when you can start to shower. What we really don't want is you sitting in a bath and lying back to soak. You'll only be able to sit in the bath up to sort of your navel to start with, and then we'll slowly allow more of that. Again, 6 to 12 weeks, we really want everything to be completely healed. Swimming in a public pool, jacuzzis, open water swimming, ponds, all that kind of thing. We really need everything to be healed, because if there's any problem with healing and you get dirty water in, then you've got an increased risk of infection. So I think in the long run, we should be able to get you back to doing anything that you want to, but in the short term, there will be sacrifices in terms of exercise. We do know that keeping your weight within the normal range and also exercising 3 times a week is for about 40 to 50 minutes is important for your overall cancer risk. That's for everybody. So we do want to get people back to their normal levels of fitness and encourage things, but we will put a little pause on.
Okay, that's all very clear and reassuring, and absolutely sounds like it's about striking the right balance between getting your body moving, but you know, not pushing it too far whilst it heals.
If you overdo things at the beginning, then you'll be 2 steps forward and half a step back. So you really just do need to do it gently. It can be a little bit frustrating, but once we get you up and going properly, then we want you just to be able to go. What we don't want is complications.
Absolutely. So we've got a question here that focuses more on DIAP surgery again. So
Yeah.
Is it possible to go through pregnancy and have a baby after this kind of surgery?
So the answer is yes, but we do keep it, the obstetricians will keep a closer eye on you. So we are not, with a DIAP, you are aiming not to affect the muscles of the abdominal wall at all. You are taking the skin and the fat. So it is indeed possible to have a pregnancy afterwards. But what we find is that for some women who are of an age where they want to have children, but they also want to have the risk-reducing surgery, they may go for the implants in the first instance because it's quick and it's simple and we're not going to interfere with the abdominal wall. Then they'll have their family, and then later on they'll convert that implant to a DIAP. It's sometimes there is less abdominal tissue before you've had children, and actually it's only once you've had children that you end up with that slightly larger lower tummy that gives us enough tissue to make 2 breasts. But yes, you can support a pregnancy and have a normal pregnancy afterwards.
Great, that's very helpful, thank you. Now a question about sent in advance about BMI. So how is BMI, if at all, taken into consideration when deciding on the choice of mastectomy and reconstruction?
So we know that if your BMI is very low to start with, that actually it can make the skin preserving part of the mastectomy extremely difficult. So a very low BMI is very challenging for someone like me, as I'm trying to remove all the breast tissue that I can find, but leave the skin and the subcutaneous tissue that's supporting the skin viable. Because if you end up damaging the skin, then it makes a reconstruction much more susceptible to infection and complications. If your BMI is very low, then it can be quite difficult to do anything other than implants, because there usually isn't much tissue option from anywhere else. And then for those people who have a higher BMI, then the risk for surgery, especially things like DIAPs, is too high, and we will ask patients to get their BMI to be lower in order to be able to do the surgery. So it's really frustrating for patients, because sometimes no matter what you do, you just can't get your weight exactly where we say it's going to be. So there is a tiny bit of wriggle room with that, but the risk for surgery, if your BMI is high, from a 10 or 12 hour operation is not to be ignored, because the risk of things like complicated infections, poor wound healing, the DIAP having fat necrosis and all sorts of wound complications, but also things like deep vein thrombosis, pulmonary embolism, and so on. So there are some strict rules around what your BMI has to be for things like DIAPs. For implant-based reconstructions, a higher BMI, you can do the implant-based reconstructions, but your risk of problems with the flap again can be the preserved skin flat or the nipple and healing can be much worse, and your risk of an implant complication, infection, or implant loss goes up. So in an ideal world, we'd like the BMI to be as normal as it can be, but there is some wiggle room.
Excellent, thank you very much. That's a really, really clear look at the choices and the risks of such surgery. We've had another question focusing on breast implant illness.
Yes.
Do you have a particular view or any essential points to tease out of that topic?
So I work very closely with a plastic surgeon who treats lots of patients with breast implant illness, and he spends quite a lot of time removing implants and all the capsule around. And certainly for some women, it does appear to improve how they feel considerably and is life-changing. So there are some women who will say that when they have implants put in, they start to feel unwell, and it's only when they come out, the implants are removed with all the capsule, that they start to feel better. it's very difficult, because if you are one of those people who and there are people who realize that they are quite sensitive to all sorts of foreign bodies, they're much more likely to have reactions to things, you know, they find even different types of clothing and synthetics affect them, then you do need to think carefully about risk reducing surgery and implants, and you need to think about whether you have any autologous options or not. So I think for some women it really is very real, and it is something that you need to consider, especially if it's something that you're concerned about beforehand. So if it is something that gives you concerns and you have autologous options, then that may be much better for you.
Great, thank you. I was wondering if you could just maybe explain the term autologous options.
So autologous is when we use your own tissue. So that there's when I said that you can either have a simple mastectomy without any reconstruction, you can preserve your skin envelope with or without your nipple, modifying it depending on how you want your body shape to be, and then you can use an implant, or you can use your own tissue. So your own tissue we call autologous. It doesn't matter where that tissue comes from you. So it can be the lower abdomen, the inner thigh, the back, but it's all your own tissue. One other thing that we have available, although I think it can be quite difficult to make a sizable breast from it, is you can do just fat transfer. So you can have something like liposuction, and we can all find areas that we'd like to improve the contour of, and that fat is spun down, and then the cells that we think would survive are injected into an area. So we can use that to try and correct some changes that we get after a reconstruction if we don't quite like the shape. But for some women, if you're not looking for a very large breast, you may be able to have your entire reconstruction done with fat transfer. It is never one operation. That is always going to be 3 or 4 operations. And again, you have some side effects from the liposuction, but we usually tend to use it as an adjunct to a reconstruction to help improve what it looks like. But there are some people who they might be particularly suitable for having their entire reconstruction done that way, but it will almost definitely be more than one operation.
Wonderful, thank you very much. A slight change of topic here, around talking to our loved ones and those close to us about surgery and kind of bringing them into the conversation. Do you have any advice for ways to include perhaps a fairly new partner into decisions or conversations around options and risk-reducing surgeries?
I think it is really challenging, all of this. I think it's not just about discussing it with partners. Sometimes it can be really difficult discussing it with children who you may not yet have wanted to talk about your personal risk, or for them yet to be worried about what may be their personal risk in the long run. So I think these things are really difficult. I think it's really important to try and be as open and honest as you can be. And I think the most important thing is that as a woman, that you choose the reconstruction that feels right for you, and that you don't feel that you're doing a reconstruction or a particular type of reconstruction for a partner or for a loved one. You have to feel that it's the right thing for you to start with. I think everything is going to feel different, and it's going to look different, and there may be no sensation in the nipples at all, and these are all things that that have to be discussed, and it can be very painful and it can be very difficult. Having said that, it is amazing how supportive and loving one's partners and family and friends can be, and I think the more honest you can be, the better. There are some people who are extremely private and find it extremely difficult. There will be women who come and see me and say, I don't want anyone to have ever known I've had this. I just want you to make things look as natural and as normal and as similar to me as they do now. There are other women who will really want to change their look completely, and that will feel very empowering to them. And for them, it will be much less easy to disguise to anybody that things have changed, because their whole upper body shape will have changed, and possibly their lower abdomen. And that will require all new clothing to be bought. You really do need to think about these things, because if we change your breast size dramatically, bigger or smaller, you may find that half your clothes don't fit anymore. So all these things have to be factored in when you think about things. There are some BRCA groups that actually have groups for the partners, so that they are able to sit and talk together. And certainly there are in some hospitals there are groups of partners who welcome other partners coming to talk to them and so on. And for some people that works really well, and for some people it really doesn't, but it should be something that your team may be able to put you in touch with. Certainly that can be helpful. I think managing children can be one of the hardest things to do, to explain why you're having something done, or why things don't quite look the same. And again, that has challenges. I find being as honest as you can be very helpful. I think that children do pick up if something's changed and they feel that they're not being told something, but it's a very individual thing. Young children particularly seem to be very fait accompli with all of these things. And even patients who are sent home with drains and things, young children don't seem to be worried about it. In fact, I've had a few patients who told me their young children wanted to take their drain to show and tell, to show all their classmates about it. So if you're quite relaxed about these things, sometimes it pays off.
Fantastic. Another question here around recovery, or preparing for surgery, I should say.
Yeah.
What's the one thing, or I'm sure many things, you would suggest to someone to prepare for the mastectomy or reconstruction?
I think you don't want to go into the hospital with too many things, because especially at the moment, you have to get yourself out of there and there are no visitors. So I think pajamas, something that does up at the front, things that are quite easy to get in and out of. I personally don't like sitting around in my pajamas all day long when I've had an operation. So I think a loose pair of tracksuit bottoms and a top, because I think if you get dressed in the day, it starts to differentiate a bit between day and night, and that can help a little bit. In terms of what to pack in your bag, I would seriously suggest, especially at the moment, that you think about some electronic devices for communication, because no loved ones are allowed into the hospital to see anybody. So you feel utterly miserable as you sit there on your own. You can't communicate with anybody, and then you realise that your phone charger is not going to work for very long, and so on and so forth. So that's the type of thing that you need to bring into the hospital with you. In terms of preparing, there is usually a special diet that you need to follow just beforehand. So we try and give you a high calorie diet beforehand, or some special build-up drinks. So you should talk to your team about that. Otherwise, I usually say to everybody, everything in moderation. If you're used to exercising, please carry on and do it until afterwards, but pause your gym membership for a couple of months after that. Make sure your freezer is full of food, or you've got your Ocado or Tesco deliveries ready. Try and be organised for all that sort of thing. Very often women have got lots of other things going on, so there's work that they need to think about, there's home that they need to think about, there's all the things that you ordinarily do. So trying to make sure that all of those things are covered so you can be a bit relaxed about it is really helpful, because I think you're going to need all your energy on your healing, and you don't really want to be worrying about whether the sports kit's out, or whether everybody's got their favourite dinner on Sunday and so on. So that type of thing. So being as organised as you can beforehand, I think, is very helpful.
Fantastic. That is really helpful and practical advice, and I think it's also really useful to touch on the different ways that someone going into surgery might need to be prepared during the current circumstances. And you did touch on this in your earlier, but I think it's maybe just good to recap. Someone got in touch to ask about they're due to have surgery in about a month's time, but there's perhaps a little question mark over going to hospital during COVID. And so I think any advice on, timing, whether it's good just to go ahead and talk to your medical team if you're concerned, if you do have an operation on the horizon right now.
So currently, there are no concerns about operating on patients. We, within the hospitals of the UK, have now understood much more about how COVID affects patients, and we have clear pathways of how to keep patients for elective surgery safe and separate from those that may have had COVID. Prior to surgery, you will be COVID tested. That's the same for everybody who's coming in for an operation, and you will be given some quite strict guidelines around self-isolation once you've had that COVID test. So it is very important that you do that. But otherwise, there are no concerns, and we really do want to see patients in hospitals. Medical practitioners are ready to support patients if they have any medical concerns at all. We saw a massive drop-off in patients going to GPs and accident and emergency departments. People were not presenting even with very important medical symptoms, cancer, heart attacks, and so on. So if you have any concerns, please do speak to your medical practitioners. We do want to see patients, and we can keep you safe. But there are no concerns regarding operating during COVID at the moment, and things are, may change, and I think it won't be a problem in terms of keeping you safe in hospital. It will be more around whether we have a capacity issue again. But I am very optimistic that that we will be able to continue with all time critical surgery. Whether all risk reducing surgery will continue just depends on how things happen. We just don't know at the moment.
Thank you, and I think that's a really important couple of messages to put across, and I think also a really great place to wrap up this session here. So thank you so much for your time. I mean, I found an incredibly helpful and informative session. I'm sure lots of questions are answered. So thank you to everybody for joining as well. If you did have any questions that you did want to find out more information on, please do get in touch with us at braca@ovarian.org.uk, and we'll do our best to get the information that you need to you. I hope you found this really useful, informative session. So thanks once again, Joanna, and thank you to everyone for joining.